Broadcasting live spine surgery from Deuk Spine Institute, Surgery Center of Viera on, what is today, July 25th?
Yes, sir.
2019. And our patient this morning is having a Deuk laser disc repair. This is an endoscopic spine surgery, endoscopic transforaminal disc repair. And he has two symptomatic herniated discs, L45, L5S1, based on all of his preoperative diagnostic imaging exam. So we're going to confirm that this morning. Sir, this is Dr. Deuk Majin. We're going to get started, okay? Our patient is awake for the surgery in the very beginning. We're going to put him to sleep in a few minutes. Sir, I need you awake for the very beginning, okay?
Yeah, I'm wide awake.
Now I'm going to give you some numbing medicine. You're going to feel a little stick and burn, like a little mosquito bite and some burning. That's just the medicine going, and it's perfectly normal. Okay? Now, if you're feeling any pain or discomfort, you just say ouch, but don't move your body, just say ouch, and I will give you more numbing medicine. I'll let you know if there's any problems, but I've done over 900 of these surgeries. I've never had a problem during the surgery, so I don't anticipate any issues. So if you feel uncomfortable, just say ouch, and I'll give you some more numbing medicine, all right? And at some point, we're going to put you to sleep. All right. And I'll be talking mostly to the audience. They don't know who you are. They just see a back here, but they're going to be watching our surgery. All right. So the very first thing we need to do is confirm our levels. Where's the MRI? Let's go ahead and get that up. Yep. So he's got a pseudodisc on the MRI, basically an S1, S2 disc. And the L5S1 is a real size disc. The pseudodisc is at the taper, and that's kind of what we're seeing there. So I feel pretty confident that, can you show us 5-1? Jordan, no, not with your fluoro. Point to it on the screen. Yeah, that's what I think is L5S1. You agree, Dr. Santiago? Right? And then the iliac crests come up and almost make it to 4-5, but not quite. Okay? So we're all in agreement on the levels? Okay. You're going to feel a little stick and burn, all right? Remember, you just let me know if you're uncomfortable, and I'm going to give you some more numbing medicine. Yeah, it does burn, doesn't it? So our patients are always going to be awake for the very beginning of the surgery, and the reason for that is I need his help. There's two things I need help with. Number one, needle down, 4 cc's injected. I need his help for navigating to make sure that we're free and clear of the nerve root. And I need his help on the discogram. Discograms are done usually what are called evocative discograms, where we're trying to evoke a response by pressurizing or stimulating the disc that we think is causing the patient's back pain or neck pain. Discograms are usually done in the lumbar or cervical spine, where we're not really sure which discs are causing symptoms. All right, just relax now. That's all normal. That's just, we're putting numbing medicine, okay? You'll feel little sensations. I apologize, but everything's okay. We're just putting numbing medicine. Go ahead and turn the volume off on the music. Okay. Do you have any type of music you like to listen to? Shot. Anything in particular you want us to play?
Actually, it doesn't matter. Once I'm out, you can play whatever you want.
Turn it off, please. Off. Right. We don't want you playing the air drums or guitar while you're having surgery. Let's go with a lateral view, please. So you can see on the front to back view, we call it the AP view, there's a little bit of rotation at L5S1 between the spinous processes. That's the one of the injured discs.
Make sure it's
Did you ever figure out what happened last time
yeah,
with the drape?
yeah.
All right. So we're going to need to, yeah, either drop the table or bring the fluoro up. That's good. All right, shot. I mean, I can see the needle. It looks perfect, actually. Our trajectory is really quite good right now. So I feel the facet joint, and I want to go around it. Shot.
We have no needle standby, just to let you know.
I don't think we're going to need them.
Okay, good.
Shot. So if you have questions during the procedure, feel free to ask them. I do take questions. Shot. When I say shot, what I'm asking for is I'm asking my assistant, Shot, to take a picture, basically. It's an x-ray shot. There's not really a shot that we're doing in the patient. We're doing an x-ray picture. Shot. And that x-ray picture is what I use to guide my surgery. Pretty much everything in spine surgery is shot related to the bones of the spine. Are you comfortable?
Yeah, I can feel you kind of creeping along.
That's funny you say it that way because that's exactly what I'm doing. I've never had a patient describe it as creeping along in 13 years, but that's what I'm doing. I'm creeping along slowly and carefully. Are you comfortable?
Yeah.
All right. No pain anywhere?
Well,
Huh?
nothing from what you're doing.
Where are you having pain, Shot?
Well, the thoracic and cervical muscle too, so I'm getting a little in the neck and the arm.
Oh, your neck is bothering you?
Yeah.
Can we make your position of your neck any better?
No,
That's it?
yeah, we'll keep that control.
All right. If we can do anything, you just let us know, okay?
No,
So everything's going very well. We're making our incision. It's only 7 millimeters long. The whole surgery, folks. This is one of the things about the Deuk laser disc repair that's very different. It's not different from other transforaminal endoscopic surgery so far. This is pretty similar. There are some things that I do differently. And I learned from the Grand Master in the world. His name is Dr. Tony Young out of Phoenix. I have tremendous respect for Dr. Young. But even Dr. Young's technique, he would have a 10% nerve damage rate. And of course he didn't call it nerve damage. He called it something else like irritation, or he called it he said that there was a nerve called a funcular nerve, I think it was. Anyway, I've had 0, so I'm actually have better results than the Grand Master himself, and much better than Parvis Cambin, who started the surgery back in Pittsburgh in the 70s. So Dr. Cambin would have 50% of his patients would have nerve damage, but they're both, Dr. Cambin and Dr. Young are both orthopedic surgeons. I'm a neurosurgeon. We have, I think, a better understanding of the neural anatomy of the spine, and we're able to better navigate around the nerves. So my technique has allowed me to and my patients to have, I think, a better outcome and a better procedure. Are you comfortable?
yeah.
AP? All right. Well, everything's going well, as I said, and hopefully we'll have you to sleep soon. Okay? You need to go to sleep?
No, I need a good sleep.
Oh yeah, we'll give you a decent sleep. It's not going to be a long sleep, but it'll be a decent sleep. Okay? Shot. All right. So far it looks pretty good. Probably be a little lower, but I'll see where we are in the lateral view. So what's unique about this surgery, and when I say this surgery, I'm talking about transforaminal disc surgery, is it's the newest, latest, and the best in spine surgery. And the reason it's so much better than traditional open surgery is, one of the reasons is you could see the incision is only 7 millimeters. So whereas everyone else is making big incisions, relatively big incisions, of course, even with a microdiscectomy, it's 21 millimeters. Is that uncomfortable for you?
It was just like a hook, like a thin hook.
Yeah, that was your lumbosacral fascia. That's your facet joint. Probably gonna have to be a little bit more lateral. Shot. So every other type of spine surgery that's typically done for degenerative disc disease or herniated disc is done in the midline, right through here. And all the other spine surgeons that do that kind of surgery, they actually have to they have to remove bone, the lamina. They have to open the bone, and what that does is it definitely weakens the spine. But they don't know any other way to do it. And this technique, as I said earlier, was developed by Dr. Parvis Cambin in Pittsburgh. And Dr. Cambin was doing these surgeries. He had to develop all the instrumentation himself, all the equipment. And basically, it's interesting. I think your 4-5 herniation is actually bigger than a 5-1. I could feel it way out here in the foramen. Anyway, he did develop all that equipment and tools, but of course the early stuff was not really that good. So people had to modify it over time and make it better. I think I'm hitting just the superior end plate there, so I'm gonna need to come up a little bit. Are you okay? So some of the challenges this patient presents is he's a very big guy, a lot of muscle, very muscular. Muscular backs are thicker and they're harder to navigate. That's it right there. Okay. And the other issue can sometimes be the actual facet joint. Once you injure your disc, there's typically going to be some facet changes that ensue. And obviously, you don't want facet changes. Again. Oh, we're so close. We're right there. So what I'm trying to do right now, folks, for those of you watching, I'm trying to get into his L4-5 disc. We've successfully navigated into 5-1, and I'm just having to reposition because of his facet joint is displacing the needle, and it's displacing it downward. So I have to try to reposition it. I think that time I was successful. Let's get an AP just to confirm positioning. So you can see so far we've already made the incision. It's tiny. So one of the advantages of this surgery over all other spine surgery, and by the way, there's only about 10 surgeons in the United States that know how to do transforaminal disc surgery, know how to do the approach, and their results are not as good as the ones at Deuk Spine. It's very important to understand when you go to different locations for your surgery, you're going to get different results because the surgeons do things differently, right? And so you want to go somewhere where you're going to get really good results. The way I do the surgery is very different than everyone else. We do what's called an annular debridement, and I published that back in 2012. as the first surgeon in the world to describe and do annular debridement with the laser. Basically, it means cleaning up the annular tear so it can heal. That's where all the back pain comes from. Are you comfortable?
Yeah, I'm fine.
All right.
Whoa. No, that's pressure.
How bad is that on a scale of 1 to 10?
Oh.
Shot.
Well, I can feel it's cut down, but it was just
What was the highest it went to?
when you just did that.
Yeah.
Oh, maybe a 4 or 5.
Okay.
Just about the pain that I had before
Yep.
you started. It's about the same.
Yeah, so it's typical pain, 5 out of 10, concordant. All right. Well, we found one of the damaged discs. The good news is your disc herniations are not huge, so they're actually that really should be amenable to this surgery, as long as you don't re-injure your back, you know. That's the main thing, is you just have to avoid doing anything that will re-injure your disc in the recovery period and let it heal. You understand?
Oh, yeah.
Yeah, just give it a chance to heal. Shot. All right, are you comfortable?
Yeah, fine.
You know what follows that question, right?
Yeah. Oh.
How bad is that on a scale of 1 to 10?
Like
7 out of 10 shot? That's your typical pain. You should be taking a shot without me telling you, Jordan. Come on. I go in, they have a response, shot. Okay? All right, let's get a lateral. That was your L5S1. That was the bottom disc. So clearly more painful. Yeah, fine. Clearly more painful, okay? We're going to put you to sleep now. When you wake up, we'll be done. Was that bad?
No.
Right. All right, good. Well, better than the RFAs. Ah, well, thank you. So there you hear it. This surgery so far has been less pain and better than a pain management procedure called an RFA, or radiofrequency ablation. Go ahead and count to 100 by 1, starting at 1. Count out loud, please.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11.
We have a question.
Yes.
We have a viewer asking, can this surgery be used to treat severe sciatica?
Can this surgery be used to treat severe sciatica? Yes, absolutely, 100%. So, just so you understand, severe sciatica comes from primarily 2 causes. The first is a herniated disc, like this patient has, that's pinching the nerve going down the leg, called the sciatic nerve. Remember, the sciatic nerve is actually made up of about 4 nerves that come together, and those nerves come together in the area in the back and then run down kind of through the buttock area and down the thigh, leg to the foot. So one of those nerves, actually in his case, 2 of those nerves are being pinched and irritated in L45, L5S1. So number 1 cause of severe sciatica would be pinched nerves from herniated discs or spinal stenosis, okay? That's what we're treating with the surgery today. The second most common cause, in my experience, and it's far less, but significant, would be piriformis syndrome. That's Piriformis syndrome. And that's a torn muscle in the buttock. And that muscle in the buttock, because the sciatic nerve usually runs just under it or in between the muscle fibers, when the muscle's torn, it causes inflammation. The inflammation gets on the sciatic nerve. It can cause sciatica. So those are probably the 2 most common causes that I see in practice, seeing thousands and thousands of patients with back problems. So to answer your question, yes, this surgery can fix the most common cause of sciatica, which counts for about 90%, even severe sciatica. It won't fix the piriformis syndrome. That's a completely different procedure. All right, so we were talking about the advantages of this surgery, and one of them is that you don't drill any bone away. You don't take any of the bone of the spine away. The other is a small incision, obviously, and no muscle damage, really no scar tissue. We're not creating any scar tissue with this procedure. So open surgery creates scar tissue, a lot of bleeding. Bleeding creates scar tissue, a lot of trauma to the bone, the muscle, the ligaments, all traumatized from open surgery. This is a endoscopic surgery, so we don't get all that trauma. All right, so the recovery period is much shorter for this surgery. It's an hour recovery, then people are pretty much back to normal. Whereas with open surgery, the recovery can be weeks or months or even years. So this is A much better surgery for herniated discs because the recovery is shorter. Also because the scar is much smaller. You know, in the skin, it's tiny, it's 7 millimeters. And there's no deep scar tissue that forms, okay? And you're not removing any bone from the spine or ligaments. So what happens when you start taking the bone out of the spine like every other spine surgeon does? Well, you're going to get instability. You're weakening the spine. Imagine if you took your house and you took out a quarter of your house's foundation. What do you think is going to happen? Well, over time or very quickly, the house is going to start to sink, okay? And that's exactly what happens with the spine. So why do doctors do it? They do it because that's the only way they knew how to get to fix a herniated disc. And that's called collateral damage. So in medicine, there's collateral damage that occurs with treatment. Every doctor knows that. Every doctor knows that every treatment we do has risk and many times inevitable damage to other things to fix a problem, okay? So the nice thing about transforaminal surgery is there's no collateral damage at all except the skin. The skin incision, which is 7 millimeters, is the only damage. Everything else, the muscle underneath the skin that we're going through is spread open. It's not cut. It's spread apart, and it comes back together as soon as I take this tube out. The disc itself is what I get into next. And let's go with an AP real quick. And the disc, we're entering the disc right where the herniation is, literally at the herniation. So we're not causing any damage to the normal disc. Whereas other surgeons will actually have to cut the normal disc to get to the herniation, usually. So you can see the dilator, the tip of the dilator. We're getting down to the herniation, following the guide wire. Yep, that's fine. Let's go back to a lateral view. We're starting with L5S1. We're going to do the L45 next. Yep, we're right on the disc. So I don't want to take the guide wire out, because if I do, and I'm not embedded with the tip of this in the disc, then I could actually shift position, and that would be bad. I could end up being outside the disc, and I don't want to be outside the disc. Look how easy that goes. It's going easy, shot, because there's a giant tear right there. Okay, now I take the guide wire out. I'm ready to advance this thing, the dilator, without a guide wire, because I'm inside the disc. I'm safe. The patient's safe. We're not going to hurt anything. And the tool cannot go somewhere it's not supposed to go. Once it's trapped in the annulus and the tear, it just goes through the path of least resistance. That's the tear in the back of the disc, and it goes right into the center of the disc. So the technique I'm using is called the inside-out technique. I've talked about it before. There's an outside in and an inside out. The outside in is more popular with pretty much one surgeon that I know over in England. Is Dr. King, and he only does lumbar. And the outside in technique is more dangerous, in my opinion, far more dangerous, which is why I don't do it. He basically starts in the foramen and then hopes to end up inside the disc. But there's a nerve root out there and blood vessels, and it's very risky. Okay. I find that Dr. Young's technique, Anthony Young, who does the inside-out technique, he starts inside the disc and works his way out, is a much safer technique. You're much less likely to injure anything. And for me, surgery is all about safety for the patient. What's the safest way to fix that problem? The least invasive, safest, and it has to be a fix. I'm uncompromising on fix. So patients don't have surgery but to be fixed. Now, we do have people, obviously, who have surgery and they can have pain afterwards, but it's not coming from their disc. It may be coming from a different location, like a facet joint or something. But my goal is to fix the pain from the disc. And that's what I intend to do today with this patient. Zach, any more questions?
Not yet.
So the other thing you notice here, if you're a surgeon, is that all this surgery is being done through one 7 millimeter incision. I'll show it to you when I'm done. It's tiny. But it's basically an incision big enough to get the tubular retractor in. And a tubular retractor just means it's a tube and it moves the muscle aside. and other soft tissues aside, so I can get down and fix the disc. Now what's nice is I can actually usually fix L3, 4, 4, 5, 5, 1 all through one incision. We're not doing L3, 4 today, we're only doing 4, 5, and 5, 1, but what I'm emphasizing is that a surgeon can fix 3 discs usually with one incision. I've even done 4 discs with one incision. It's 7 millimeters. So you imagine the recovery is just so quick for these patients. Literally, people go back to work the next day. Of course, they're going to have a restriction with no bending over at the waist to pick things up and no lifting anything over 25 pounds for the first 6 weeks. But you can go back to work doing what's called light duty, which just means you have some lifting restrictions. All right, so here we are inside the disc. I went down the tube, and you can see the inside of the disc. And actually, this area doesn't look too bad, so I don't see any fragments right there. So let's get the laser going.
Yes, sir.
Our laser is going to be at 30, please.
Yes, it's a 30 watts laser. Hertz.
Perfect. Thank you. Whoa.
This light's gonna go off, June. This one next to me, and that one, Dr. Chantel, you can move a little bit off. In that case,
All right, so we got a little bit of, let me give you the laser off. We have a little bit of bubbles on the end of the scope, which I'm going to wipe and try to make it clear so you all can see. I can see good enough, but I want everyone else to be able to see as well. I've done so many of these herniations that I know I don't need a perfectly clear picture. I know the anatomy well enough. All right, so we're ready to get started. Laser is back on. Never want to turn the laser on while you're inside the tube. Very bad. Luis, have we heard back from Germany on the lasers that we sent, or the tubes we sent in?
Not yet, sir. Not yet. I can contact them today and tomorrow. Yeah, it's gonna update them.
Huh?
We have. You mean laser or the scope?
Scope.
Yeah. No. We at least we have like 6 more. And
Right, I
that
know,
one,
but-
we need that one to see what's going on.
How many are in Germany right now being
We
repaired?
have 6.
How many are in Germany being repaired?
Only one, sir.
Only the one. So we got the other one that was broken back.
Yes, sir. Yes, sir. And it's pretty good. It's very nice. Yes,
All right. So if you're watching the surgery today, which is the 25th of July 2019, you're watching live surgery. There's actually more scar tissue here than I thought. Just by looking at it, it's not normal disc, unfortunately. So this is a condition that's long been known as internal disc disruption, or IDD, and it creates a lot of scar tissue inside the disc, and you can't see it on MRI. That's why they call it internal disc disruption. There's no external manifestation. So you can still have a herniated disc at a level where there's internal disc disruption, and the internal disc disruption needs to be addressed as well, but there's just a lot of scar tissue here. So this is not normal. See how long it takes for the laser to cut through the tissue? It should be, those strands right there are all scar tissue. Those strands, white strands. So I'm going to clean this up a bit. But really the biggest source of pain is going to come from the end of this disc, laser disc repair, Deuk laser disc repair procedure. And that's near the surface of the disc where the tip of the herniation is. And the reason for that is that's the most important thing to fix for surgeons thinking about doing this, because that's where the most inflammation is going to be. That's where the nerve root contact is going to be. That's where you're in the epidural space, in the foramen, and you need to fix that area, because all that inflammation from the annular tear that you have to fix over there is going to be leaking out onto the nerve root, causing radicular symptoms, like a radiculitis usually, even a radiculopathy if it's bad enough with all the scar tissue. So the blue fiber you're seeing, folks, is the laser. I use a Holmium YAG laser. I think it's the best. That's what I've been using now for 15 years doing this procedure. And the Holmium YAG laser is a medical laser. I use different power for the neck versus the lower back. If you're interested in this surgery, which is really, in my opinion, the best surgery in the world for a herniated disc, we can fix herniated discs in the neck and herniated discs in the back. I cannot do a thoracic disc herniation. It's just not safe. and we've got rib heads in the way that block access through the foramen to the disc. So really, this is a cervical and lumbar, and fortunately, that's where most people's disc problems manifest themselves, in the neck or the back. So if you've got neck pain and a herniated disc, or back pain and a herniated disc, this procedure you're watching is the most advanced surgery in the world for those problems. And it has the smallest incision, the fastest recovery, the best outcome, lowest chance of complication, and just the happiest, most satisfied patients there are. The recurrent disc herniation rate for this surgery is 1% in my hands. In my patients that have this surgery over the last 13 years, 1% get another herniation at the same place, at the same level. So they re-injure the disc. You know, I give my patients restrictions after the surgery to keep them from re-injuring the disc, but the fact of the matter is every single patient that's re-herniated their disc has done something they're not supposed to do. They're just feeling so good, they want to get back to normal. Look at this right here. That's the annular tear, folks. You see it? See that blue and that white? You see the torn fibers right here? That's your annular tear. That's where all the back pain comes from in this patient, and any patient that has discogenic back pain. Discogenic means it comes from the disc. Disc is the structure. Genic means genesis, or create, or originate. So discogenic pain is pain that originates from the disc. Facetogenic pain is pain that originates from the facet joint. This patient had their facet joints treated already, and it didn't work. So after we treated the facet joints, we had a really good idea that it was the disc herniations. Even though they weren't huge, we had a really good notion that that's what was causing his pain. So that's why we offered the surgery to the patient. We don't need to do the laser surgery on a patient's disc when the disc is not the source of their pain. So many people have herniated discs. Very few people have symptoms from them. So it's our job at Deuk Spine Institute, and every other doctor's job, to figure out whose disc herniation is causing symptoms. And this is one place that we excel over everyone else. I can't tell you how many people come to me from around the world and they say, oh, I've been told there's no surgery that can be done to fix me. There's no need for surgery. I have a small disc herniation. Well, guess what? Small disc herniations cause big pain. They absolutely do. And big disc herniations can cause no pain. So never judge your size of your disc herniation to be proportional to your pain. By the way, does anybody know when Godzilla movie is being released on iTunes? I've been checking every day. I've already pre-ordered it. It's so frustrating. I don't know why they don't let us watch it at home. It's not even in the theaters anymore. Doesn't that bug anybody else, or is it just me? That period of time where the movie's no longer in the movie theater, but it's not on pay-per-view or iTunes. Anyway, getting back to the surgery. Painful herniated discs account for people's chronic back or neck pain about 20% of the time. The rest of the time, the pain comes from things like the facet joints. So that's why we tested this patient's facet joints and treated those first, because we wanted to make absolutely sure that they even needed surgery. If your facet joints are the source of your pain, you don't need this type of surgery. You don't need a fusion. You just need a rhizotomy, and it needs to be done by a really good doctor. We have very good doctors at Deuk Spine Institute to do rhizotomies. So basically, we can do anything that your spine needs done. We don't do tumors. We don't do infections. We don't do, complex fractures. Of course, I can do those types of surgery if I have to, but our practice is limited to really what 98% of patients with back pain have, and that is the herniated discs or facet pain, or piriformis syndrome. So that's what we treat. A lot of people think you come in, have the surgery, go home, and you're done. But really what's an important component of recovery and having the best outcome possible, you have to do physiotherapy. and not just any physiotherapy. You have to do the right exercises. By the way, this is all damaged disc with scar tissue. So this is all internal disc disruption. It's part of the annular tear. You can't see it that well on the MRI. That's why we do free MRI reviews, folks. Anybody interested, send your MRI into Deuk Spine Institute. We'll do a free review. And the reason is simple. Radiologists miss this stuff. Honestly, I would miss it too if it wasn't for all the experience I have doing this type of endoscopic surgery, where I'm actually looking inside the disc. Just with you guys, as you can see, we're looking inside the disc right now. We can see all the scar tissue. There's no other way in the world to see this except endoscopically. So if you get an MRI, you won't see it. If you get an X-ray, you won't see it. If you get a CAT scan, you won't see it. If you get a nerve test, you won't see it. You know, the only way to see it truly is endoscopic surgery. And there's really very few surgeons in the world that know how to do this endoscopic disc surgery. And very few that know how to do it really well. And the Deuk laser disc repair, in my opinion, is the best of the endoscopic disc surgeries. All right, Zach, we have any questions from our audience?
We do. We have a viewer asking, are there any advantages? Are there any advantages to this surgery over artificial discs?
All right, so somebody is asking, are there any advantages to this surgery over an artificial disc surgery? The answer is 1,000% yes. I want you to understand what we're doing. We are literally doing the same treatment that an artificial disc would be, except for an artificial disc, they're going to cut your belly open, which is extremely risky of damaging your organs inside. The surgeon is then going to clean out your whole disc, remove it, and there's going to be a giant space between your bones, and they're going to stick a metal and plastic disc in there. Now, understand, we're not taking the whole disc out, we're only taking the herniation out. And so we don't need to put an artificial disc in. So this is 1,000 times better surgery. It's safer. We've had 0 complications doing this procedure. Artificial disc surgery has lots of complications. And I'll be honest with you, the only people that publish on artificial disc surgery are the surgeons that, that publish basically their best outcomes, and their best outcomes aren't even close to the results we get here. So this is a much safer surgery, smaller incision, really no internal scar tissue, whereas artificial disc surgery is going to have a very unsafe approach to the spine, which is an anterior approach going through the front, which is the most dangerous of all approaches. What's the approach? Approach means how the surgeon gets to the part that needs to be fixed. This is a herniated disc. They're always in the back of the disc. They're always in the back and to the side. So that's where the nerve root is. So that's where the herniation is. That's the weakest part of the disc. That's the part that always gets injured. And that's the part that gets symptomatic. So we know that the disc herniation's in the back of the disc, yet the artificial disc surgery is through the front. So already the approach is wrong going through the front. You should be going through the back. But that's the only way they can put an artificial disc in, is through the front/side. So that is the wrong approach in my opinion. It also is very dangerous. It's, of all the surgeries done through the back, the side, the front, it's the most risky and dangerous approach. That's been peer-reviewed, published many times. And then, of course, the disc can pop out. That was a big problem for many years. That's why a lot of surgeons like me wouldn't put them in. We didn't want our patients to have their artificial disc popping out. I was trained to do the artificial disc. I was trained at the University of Florida in Gainesville. That was one of the places that were doing a fair amount of artificial discs. And this is just a much better surgery. Tiny incision, minimal to no risk to the patient of injury or damage. And the recovery for this surgery, folks, if this patient allows us to record him in recovery, he's going to go home an hour after his surgery. There's no artificial disc surgery where they send you home an hour afterwards. I admit they've gotten better at recovering patients, so now they go home the same day in some cases, but most patients still stay overnight. But there are doctors that are doing artificial discs where you go home the same day, but it's not even close to the same surgery. With this surgery, you're keeping your own natural disc. I'm not taking this patient's disc out. With fusions and with artificial disc, the disc is usually taken out. Plus, with this surgery, we're going straight to the source of pain, which is this tear right here that I'm fixing. And you can see I'm only fixing the tear. I'm not going to put any metal in the patient. I'm not putting any plastic. I'm not putting anything. We're just fixing the disc, and we're going out. We're done. And this patient's disc will heal naturally. That's why the Deuk laser disc repair is a much more natural surgery, because we're not putting anything artificial that stays in the patient. This is just all around, hands down, not even a close comparison to artificial disc technology. This is the next level. I want you to think about it for a moment. A long time ago, just think about hip surgery or knee surgery, right? A long time ago, we used to fuse hips and knees. And then they went to the artificial hips and knees, artificial joints, just like an artificial disc. And then now they're going to endoscopic surgery. So that's the next level of advancement in many cases, okay? So this is endoscopic spine surgery. This is the most advanced, latest type of spine surgery that can be done. So it's beyond artificial disc. Unfortunately, it took the United States a long time to catch up to the rest of the world with artificial disc technology for the spine. And, you know, people were putting artificial discs in 20, 30 years before the United States, but there were a lot of really bad designs and they didn't work very well. But by the time they came to the United States, the artificial disc technology is actually really good. And it was coming in when I was in training in Gainesville, Florida, I was there from 97 to 2004, and we were putting in artificial discs back in probably 2000 to 2004 before I left. And I'm sure they're still putting them in. But this is a much more advanced surgery than artificial disc. You're not getting any of that metal plastic put in your body. We're keeping your natural disc, we're just repairing it. So I would never have an artificial disc put in my body, ever. I would honestly, knowing what I know about the complications, I would rather have a spinal fusion done through my back by a good surgeon that has good results than have an artificial disc put in by the best surgeon. And I don't know if you folks know this, but the truth is, many patients with artificial discs, they go on to fuse at that segment anyway. That's something that the company doesn't like to talk about. But you've got to understand something about artificial disc technology too, is that many of the companies that sell it, they bought that technology for hundreds of millions of dollars, and they need their money back. They need a return on their investment. And so, you know, they're out there promoting that technology, but there's a lot of surgeons that won't put them in because they know that it's not as good as some of the other technologies, no matter how many papers they publish. I don't know if I answered the question, but I tried. And if you have a specific other question, I'd be happy to answer it. This is all inflammation, chronic inflammation, very scarred down. Thick scar tissue right here. This is the top of the tear. This is right where it goes into the epidural space, right where the nerve root is, okay? And it's so thick right there. This is a little bit of blood coming from the epidural space. There's a little bit of fat right there at 12 o'clock, some veins. But right over here is where the tip of this laser is. That's where the traversing nerve root is. And right over here on 9 o'clock is where the exiting nerve root is. So the exiting nerve root at L5S1 is going to be the left L5 nerve root. And the traversing nerve root is going to be the left S1 nerve root. So we're working right between the left L5 nerve root and the left S1 nerve root in a space called the safe area or safe zone called Cambin's Triangle. And it's named after Parvis Cambin, the surgeon that I told you about earlier from Pittsburgh who developed this approach. He deserves credit for it. He was the pioneer who developed the approach. But his instrumentation back in the 70s was horrible. And there was, I think it was 70s and 80s, but there was a lot of nerve damage as a result of his surgeries. Fortunately, we don't have that anymore. Here's some granulation tissue right here. It's pink. I'm zapping it away with a laser. That's part of the source of the back pain. That's the deep annulus. All right, we're just about done with this disc, and then we're going to move on to L45, the next disc. And any questions?
Not yet.
All right. So again, I'm Dr. Arajuk Majan, CEO and founder of Deuk Spine Institute, the pioneer of this endoscopic spine surgery called the Deuk laser disc repair. This surgery has been peer-reviewed and published. So we know the outcomes, and the outcomes are fantastic. We've had 0 complications with any of these surgery patients. In 14 years now, I think I've been doing them this month. We've had a 1% reherniation rate in patients who don't follow their instructions. Every single case was somebody who did something they weren't supposed to do. But if you follow the instructions, the herniation will not come back. Now, people still get back pain from other areas even after the surgery, but not from the disc. So they may develop sacroiliac joint dysfunction or facet joint pain, but once the disc is fixed, as long as it doesn't reherniate, their pain from the disc will be gone forever, the rest of their life. This is a permanent fix. This is not temporary. This is as permanent as an artificial disc or a fusion surgery. It's permanent. I don't expect this pain to come back. Again, I've been doing this for a long time. All right, we're done with this disc. Laser off. We're going to take a look at the exiting nerve root right up here. Actually, there's too much fat around it, so we can't see it, but that's good. And then just 12 o'clock is going to be your traversing root. Again, too much fat. So that's okay. Let me have the laser. I want to get this lateral annular tear. What separates my surgery from every other surgeon is I'm the first person to do what's called an annular debridement. And it's basically cleaning up the annular tear. In surgery, we do things called debridements when there's tissue that won't heal. And there's chronically inflamed tissue that won't heal. We do what's called a debridement. And that means you go in surgically and remove all the dead, grungy tissue that's not healing. And you cut it back to nice, clean, healthy tissue. And that's what I do with the annular debridement. Laser off. So we're done with L5S1. Oh, another thing, most spine surgeons can't do it. Anyone that does this treatment, this transforaminal approach, they won't do L5S1. I'm one of the only surgeons in the world that will do L5S1 because it's so hard to get to. And the risk of nerve injury is high, but I've never had a nerve injury at L5S1. So I'm just saying that, it's one of the things you'll notice when you're out there looking around is that surgeons won't do endoscopic transforaminal L5S1 surgery because they just don't want to have a complication at L5S1. You're hitting me in the thigh. How about giving me just a minute? Paying attention to what I'm doing. Okay? Good. You got pressure? All right, let's go ahead and come in with a fluoro. Watch Luis. Let's not beat him up too much. That's my job. All right, any questions? Watch your hand, Luis. He's going to radiate in a second. Let him know. All right, fire away. Fire in the hole. I need to see that fluoro. All right, who's in charge of that? Okay, when you see me injecting the medicine and starting to take the tube out, that's your clue to move back that video to fluoro, okay?